GI cancers and clinical trials and updates from ASCO GI. And I'm really, really thrilled that she's agreed to join us today. Let me give you a brief introduction. She's got a whole bunch of stuff here, and thank you for pulling up your slides. She is the professor of oncology, the associate director of clinical research, and the co-lead of cancer genetics, epigenetics research program at Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins University in Baltimore, Maryland. And we get the opportunity. I always do like a brief intro, let people like get to know like just who you are and like who I get the opportunity to like run across. And she was an absolute delight when we were there at Hopkins. It was just a year ago, just a hot minute longer than a year ago. And being able to kind of like have a conversation and just kind of like do like a Q&A on a panel and just a real firecracker. So, which I hope you don't take as an insult, because
oh my God, no, thank goodness.
Okay, I didn't think so.
Yeah.
I didn't think so. I thought that was a safe one. But no, I mean, for sure, you're a little bit of a firecracker in only the best of ways, that you really want somebody to like watch the segue. You really want somebody to go in there and be a firecracker to kick cancer's KRAS, right? So anyway, so with that, I'm delighted to have her here today. And if you haven't been with us before, let me just kind of like give you a little bit. I'm a patient, founder, whatever, general troublemaker. And as you're kind of going through the slides, because I have the memory of a goldfish, if I have a question, I'm hoping that I can just kind of interrupt you and we kind of make this a little casual interaction during the course of our talk today, Dr. Azad. So with that, I'm going to let you kick off.
Awesome. I have been so fortunate to be able to be in this space of KRAS and KRAS inhibition over the last few years, and I hope many of you are already aware of how exciting this space is, and I hope anything that I tell you today will only whet your appetite even more. So I know that this audience is a little bit more of a lay audience than all kind of stuffy scientists, but I actually love giving talks with my slides that I use at science meetings too, because I think understanding the science is really important to be able to really self-advocate. And so I hope that the way that I frame this is still going to be really interesting, because I think getting into kind of the nuts and bolts of the molecular part of this is really important to understand both why we're being really successful now, but also what the next steps are, because we should always be forward thinking about what's coming next and what can we do that's better than what we're doing now, even if we are making a lot of progress. And so this talk is about KRAS and GI cancers. There is exciting work in KRAS happening across different tumor types. And so even patients that don't have GI cancers, clearly lung cancer, but also in other tumor types, these drugs are active. But I'm a GI oncologist, and this is really where I'm focusing. And so I hope this data is going to be really interesting to share. So these are some of my disclosures, both in terms of companies that I consult for and also grants that I have that help fund the research that we do as well. And so this is just a graph and a series of tables that's showing how common KRAS mutations are in GI cancers. And so if you look at this, and are you able to see my arrow?
Yes, I can see your
Okay, great. So this is, if you look here, this is the percentage of KRAS mutations in patients that have different kinds of cancer. And every color here is a different kind of cancer. And so you can see that across different GI cancers, really we have some tumors that have very rare KRAS mutations, but most cancers in the GI space actually have a pretty high percentage of patients that have KRAS mutations. And importantly, every KRAS mutation is not the same. So when you get a report back on your tumor, it's not just that your KRAS is mutated, but what mutation do you have? So for example, in colon cancer and in pancreas cancer, KRAS G12D mutations are the most common mutations that make up 40% of pancreatic cancer, a little over 20%, or 25% of colon cancer, but every one of these mutations is molecularly a little bit different. The DNA of that mutation is just a hair different, but it's enough that some of the drugs really work specifically on a given mutation, and some of them work on all KRAS mutations, and that's really important. And then again, here in this table that you see here, you can see these percentages laid out a little bit more nicely, where you can see in pancreas cancer, where most of the data you're going to see today is in pancreas cancer, almost 90% of pancreatic cancer has mutations in at least one of these KRAS genes. So
Before you go back, would you go back one slide before?
yeah, absolutely.
Okay, so because we answer this question a lot, G13X, it's kind of like old school algebra. I'll let you explain it though.
Okay, so G13X just means that you have a mutation in G13, that area of the DNA, but there are a few different mutations that you can have in that area. And so X just stands for variable, right? Like just like in algebra. So it could be G13D, you see that right here, but it can also be G13V. It can be there are many other G13 mutations. So it's like a umbrella term for G13 mutations. And the same thing is true actually for G12X. You're going to see that in a couple of my slides. And that just means it's kind of umbrella covering all G12 mutations, C, D, V, R, all of them. Okay.
We have a lot of people that are Q61.
Yeah.
Just
Now,
give me a sense about how many people that would be.
So in pancreas cancer, in all the cancers, it's a rare mutation, less than 5%, and it's just another area that is mutated in the KRAS gene. And many of these drugs do not work for Q61, and a few do. So they have to be tested in the Q61 patients to know for sure if the drug works or not. Yeah. So one of the things that's really important to understand is how crazy exciting it is that we actually can target KRAS. So for 40 years, we have known about KRAS, and it is the most common mutated oncogene. An oncogene means a gene that when it's mutated, it turns on and it's bad. We don't want it to be turned on. And so it is the most common mutated oncogene in cancer, in solid tumors. But for 40 years, we couldn't do anything about it. And the biggest reason is because when KRAS was mutated, for most KRAS mutations, the way that the protein was really smooth, it was like a ball. And so you couldn't actually have anything bind to it because it didn't have like a groove in it, a pocket that you could bind a drug into. That's how a lot of inhibitors worked. Until this brilliant team from Kayvon Shokat's lab, where it was able to demonstrate that in G12C, excuse me, in G12C mutated cancers, which is the most common lung cancer mutation, that you did get a groove that could actually result in this drug being able to bind to it. And now we have a couple of dozen drugs for G12C mutations. You can see here it's the most common in lung cancer, but we do see it in our GI cancers too, both in colon and in pancreas, as well as in appendiceal cancers. And so these drugs were the first drugs that we were able to test that were KRAS mutated, and this was in the 2010s. And we were able to show across different tumor types. Again, every tumor type is a different color, and pancreas is the purple, which is the most common that you're seeing here, but you're seeing it across different tumor types, both GI and non-GI. And over on the right, you're seeing the response rate. So the number of patients that have significant tumor shrinkage, and that was over a third of patients. That's the dotted line here, is that a third of patients had significant tumor shrinkage, but you can see the majority of patients had some tumor shrinkage. It just didn't meet this preset threshold that the dotted line showed. That's disease control. So 86% of people, and I'm sure your doctors have told you or the people that you love that when you have a scan and there's no growth, that's a victory. So these people are also having a victory. It's not just the people that had the discrete tumor shrinkage that hit that metric. And so this is in particular looking in pancreas cancer and showing that we're seeing similar benefit. A lot of times in pancreatic cancer, drugs would work in other cancer types, and we try it in pancreas and it doesn't work. That is not true for these G12C inhibitors. And what we also figured out, and this is the pathway of KRAS mutation. So this right here that you're seeing is the cell membrane, the outer layer of the cell. And KRAS works by transmitting signals from that outer surface of the cell down to the DNA. You can think of these as handshakes. One protein talks to another protein, talks to another protein. But KRAS is the biggest, the loudest member of that communication. And when it's mutated, it's always on. But what happens if you can hit two of those proteins, not only the KRAS protein, but also the one that's at the cell surface membrane? So that's called a receptor tyrosine kinase. And the idea that you could hit two proteins, would that be better? Would you have better inhibition than just hitting KRAS alone? And indeed, this is data that came out of the New England Journal. That's our major journal that was reported showing that with adagrasib, which is a G12C inhibitor, when you combine it with GFR inhibitor, you do the two drugs and look at that response rate, more than 46%. Right here, you get, that's that same line, the dotted line. More patients have tumor shrinkage, it lasts longer, and people do better on this with the combination. And so this is true. We love seeing things by more than one company. So adagrasib was made by one company, but this is sotorasib, which is a different company. It just tells us that it's real, right? It's not just a random effect of one drug, that this is a class effect. The whole class of drugs has that effect. And so this was similarly showing such nice benefit with the combination of the two drug combo. And now this has resulted in G12C inhibitors being approved in colon cancer, and the NCCN is the guidelines that guide how America treats cancer, and it is how insurance companies determine whether they will pay for something or not. And so this is now on the NCCN guidelines, meaning anybody with a G12C mutation is able to get this therapy. And this is just to show you the number of different kinds of cancer. So you see small bowel and bile duct cancers and gallbladder cancer and pancreas cancer. So NCCN allows for any patient with G12C mutations to be able to be treated with this combination, which is very exciting. But this is not all there is. So there is much more that has been developing. The G12C inhibitors are the only drugs that have been FDA approved so far. But I say so far because we are on the precipice of a whole bunch of new drugs being approved. And I am going to talk a little bit about cancer vaccines because that's my particular area of interest, but also it should be everybody's interest because it is very exciting what is happening in that space as well. So now I want to move to the multi-RAS inhibitor, which is called daraxonrasib. So it has a name now. It is also called RMC-6236. So if anyone has heard of 6236, it is the same thing as daraxonrasib. And this drug is particularly cool because it hits all the KRAS mutations. It's not just G12C. So remember we talked about pancreatic cancer, about 90% of patients having mutations. Colon cancer, it's 40%. This drug has activity against KRAS mutations, regardless of which of the mutations that given patient has. And so this is the clinical data that has been presented for this drug for patients with pancreas cancer. So again, this is daraxonrasib. We're seeing response rates. This is every line that heads downwards is a tumor that's shrinking. And we're seeing all of these tumors shrinking at a disease control rate of 90%, meaning at 90% of patients with pancreas cancer that had already grown on chemotherapy, basically were able to have at least one scan where their cancer was not growing. And actually, it wasn't just one scan, it was many scans. So the median progression-free survival, meaning how long people are able to stay on this single drug before growth and before progression, was almost a year. So 8.5 to 9 months. And remember that this is doses that are well lower than the dose that is now being tested. So at the 300 milligram dose, some of us have hope that this number is going to get even bigger. And of course, we haven't even talked about combination therapies yet. And so this again is the survival that we're seeing. Now, these drugs do have side effects. So the side effect, the most common side effect you can see is 87% of people develop rash, and the rash is real. And so that is something, when I put people on this drug, I tell people that if you take a kid who had really bad acne in high school, like maybe the worst acne in high school, that is what you can expect for this particular drug. Not all KRAS inhibitors, but this particular drug. And that's because it hits all the different RAS mutations. That said, we have found there are a lot of different ways to help mitigate that rash. We give people some pre-medication, we give people creams, we can stop doses for a few weeks in between to help the rash. So most people, again, if people are able to be on the treatment for many months to years, I have someone right now who's been on it for 2 years, it means that the rash, while it's true, doesn't mean that it's not intolerable, right? So this drug is now in its final phase 3 testing prior to FDA approval. So this is the Resolute 302 study. So this is given to people with pancreas cancer. People are randomized 1-to-1. So half people will get the drug and half the people won't get the drug. They'll get just what they would normally get, standard of care chemotherapy. And then this will read out in terms of whether people truly live longer by getting the Revolution Medicine daraxonrasib drug. And we hope that this will have results in the next year or so. And so once those results are released, then we can get FDA approval. And I am a big believer in this drug and really am hopeful that it's going to really change things.
About that drug?
Yeah.
Because we actually had to start a small subgroup specific for people that are just on it, so they had a place to connect. All right, when it comes down to this, they're doing really well in general on it, but one of the biggest questions we're getting from patients that aren't on it or they've been randomized to the standard of care treatment, which feels very disappointing.
Yes.
It's incredibly necessary for the drug to be approved. The drug
Yes.
will not be approved if they can't get through the trial. And that's actually what my question really pertained to is, if you're randomized onto the standard of care, is there a hope that you're still going to be able to get that drug? Could you kind of like walk us through that a little bit and then kind of talk about that whole fast track thing? This isn't like I'm going to get this drug next month. It's not going to be FDA approved that quickly.
No. So this was a conversation that those of us that were involved in in kind of advising the company about how to do this trial, there were a lot of people in that room that were advocating for what's called crossover, which is when even if you get randomized to the standard of care arm, that if it doesn't work for you or it starts being hard to tolerate, that you can then cross over to the study drug. I think my understanding is that was a challenge when it comes to the regulators, and the regulators are the ones who have approved the drug, the FDA and the regulators. And so that's why this is the purest trial. And it is very disappointing. I have had, it is very hard as the investigator. It is even harder as the patient or the loved one of a patient. But no, you are not going to get this drug if you are randomized to the standard of care arm. And there are none of the company's drugs. Like if you go on to this trial, there are none of the other trials from this company are appropriate or available. But I showed you a slide a little while ago. There are a lot of other KRAS inhibitor studies right now. There are dozens. And so it just means that you wouldn't get this particular drug, but it doesn't mean that people should stop looking for a KRAS inhibitor in general. And I have for example, have many trials open of KRAS inhibitors. This company's agents are just one group of those studies.
So if I'm put into the standard of care treatment, okay, that arm, and I'm in that, and okay, I just suck it up and I take it. Is there something next for me, or is this it?
What do you mean in terms of the KRAS?
It's like, okay, so like I get put into the standard of care, okay, arm of this, and I accept that, and I take that, and I go through chemo, then I have progression. There's
of course, right. It depends on how someone is doing, but if someone is still doing well enough that they want to continue to pursue other treatments, there are many clinical trials. And KRAS is just one strategy, but there are multiple other KRAS inhibitor studies you can look at. And there are also other strategies. Like we're going to talk about vaccines in a second, right? So there are other strategies that you can look at that are also in clinical trials for every one of these cancers. This is not the only thing that's happening in cancer. So while it is disappointing, it doesn't mean you should lose hope about the fact that there are other options available.
And we need you to do it too, by the
Yeah.
way. Otherwise, the drug can't be approved.
Yeah. Yeah. All right. So we talked about KRAS, the multi-RAS inhibitor. This is a drug it also now has a name. It's called Zoldanarasib. But that drug is a G12D inhibitor. So it only hits patients mutations that have a G12D mutation, which is 40% of pancreas, and it is 20% of colon, but it's still only those patients with this mutation. And this is the data for that drug. And it's also very similar, as you can see, in terms of response rate and disease control rate, very similar. We don't know the duration. How long does this last? How long does the 90%, 80% disease control last? But we do know that it's really nicely tolerated. So look at that rash, right? It's in blue. The rash goes down from 90% to 10%. So it's a very nicely tolerated drug. And one of the big questions in the community is going to be, if you have a G12D mutation, which one should you do first? Is there some benefit to doing this first and having more better quality of life, and then thinking about the multi-RAS in the future? How should we give them together? There's a lot of work right now going on. We have clinical trials open where we're giving them together to see if giving them together is better than giving them individually. So lots of options. And again, G12D, this is one drug. There are other G12D inhibitors. This is a drug from a different company, seeing very similar response rates. This is a very early abstract that was presented at a meeting. So this is still an ongoing trial, and the doses are still going up, as you can see. So we're still trying to find the right dose. And then just at ASCO, because this was supposed to be an ASCO update, so I'm giving you an update at ASCO. This is another G12D inhibitor that was reported. And this G12D inhibitor, as you can see, look at that. That's 100% disease control rate. This is predominantly in pancreas cancer. If you look down below, there was also a lung cancer, and the lung cancer patients also did well. But for this talk, 100% pancreas cancer with a response rate of over half of patients. So, and when I say response rate, again, it's that dotted line, but you can of course see that many more patients than even 50% responded to this. And then I know there's hopefully time for a lot of conversation, but I'm going to just share a few last slides about vaccine-based therapies before we start chatting. So KRAS mutated cancers are different, not just because the tumor cell itself has a KRAS mutation, but the area around the tumor, we call that the tumor microenvironment, is actually different in KRAS mutated cancers versus KRAS normal tumors. So in KRAS mutated tumors, we have a lot of different immune signaling that is in a bad signaling circuit, meaning we've got immune cells. That's what these MDSCs and regulatory T cells are. These are immunosuppressive cells that suppress the immune system. Don't let the immune system attack the cancer. We have other immune cells that, when we look at the ability of those immune cells to kill cancer, that's tumor-specific T cell function. That's what it means, that we're not getting the same kind of killing from these T cells, these immune cells that we would want to see. So something about a KRAS mutation also has impact on the area around the tumor. And what we need is for this tumor to be able to recognize what a normal cell is versus what a cancer cell is. So even though they look pretty similar, there is a difference, and KRAS mutations help hide what's the right normal versus the cancer cell. And so that's why it's so important that we also think about the immune part of the KRAS story. And so this is a drug that is a vaccine. This drug is called LI-002, which is a vaccine against just this vaccine, when this was reported, was just against G12D and G12R. They have now expanded this vaccine, so it includes more KRAS mutations. But they gave this vaccine to a very certain group of patients who had already had surgery. Their cancer had basically been cleared surgically, so they were what was called NED, or no evidence of disease. But they did have some tumor markers that were still elevated. They did have ctDNA that was positive, like Natera testing. So something was there that was making us worry that they were at high risk for recurrence. And when they vaccinated patients with this vaccine, what you can see down below in this bottom panel is that they were able to clear that tumor marker or clear that ctDNA in a bunch of the patients. So they were able to see, this is a biochemical response. It's not a response of tumor because you can't see any tumor, right? If you do a scan for these patients, you're not seeing any visible tumor, but there are markers that are making us worry that they have something going on that's going to pop back up. And this vaccine did clear those tumor markers. And so they have already fully enrolled a randomized phase 2 trial of the next generation of that vaccine. And since it's already randomized, I'm very hopeful that we will get results of this vaccine next year. Similarly, at Hopkins, we have created a vaccine. Our vaccine from the get-go had multiple mutations of KRAS, and we actually gave it with immunotherapy. That's ipilimumab and nivolumab. These are immune checkpoint inhibitors. And we gave it to 2 different groups of patients. So we gave it to people with pancreas cancer who, again, were NED. They had no evidence of disease. Their cancer had been fully removed. But we know that pancreas cancer, even that has been fully removed and has and gets chemotherapy, that patients have an over 50% chance of recurrence. And we also gave it to a second group of people that had metastatic advanced cancer, colon cancer. So those patients had disease visible. So those were the 2 different groups of patients that we gave this vaccine to. And what we saw in the panels on the left, what I'm just showing you is that we saw the immune cells pop up, the ones that were against the KRAS. We were able to show that KRAS specific immune cells increased, just like we would hope with a vaccination. But on the right, and you can see this is a very small number of patients. This was a pilot study, so it was only 12 patients. But in the patients whose T cells popped up and we saw these nice responses, those patients were less likely to have a recurrence. But in colon cancer is where we have really been excited, because we actually saw tumor shrinkage, which has never been demonstrated with a vaccine-based approach in colon cancer. And we even saw tumor shrinkage in the liver. And for many people, if anyone who knows what's happening in the colon world right now, there's a strong feeling based on data that liver metastasis doesn't respond as well to immunotherapy, even new novel immunotherapies. And so now patients with liver disease are being excluded from clinical trials in colon cancer. And that is 60% of colon cancer has liver metastasis. So we're basically excluding the majority of patients in the new drugs when we look at immunotherapy. So we're really excited about this because we are seeing responses in liver. And because of that, we actually have moved forward on a clinical trial in metastatic colon cancer and pancreas cancer as well. This is my colleague, Eric Christensen. He is running a clinical trial of our vaccines in patients that are going to have surgery for pancreatic cancer. So this is when a patient presents and we know that they're going to be able to go to surgery, what if we give them this vaccine with immunotherapy before they go to surgery, and afterwards, will they do better? And then we also have another study for patients who have something called IPMN. So these are benign growths that can turn into cancer. What if we vaccinate? Can we see those KRAS specific immune cells go to that benign tumor, and does that help in terms of not developing a cancer? So kind of a prevention approach. So we have a whole bunch of studies ongoing right now in pancreas, colon, bile duct cancer, as well as in lung cancer with my colleague, Dr. Marone. And so that's the end of my slides, but I just, last couple of things is that if a patient has a KRAS mutation, we are just a couple of heartbeats away from KRAS therapy being a part of their treatment. And whether that's in the adjuvant setting after surgery, whether that's in the metastatic setting, we're very soon going to be in a world where there's going to be a powerful option for all of our patients with KRAS mutations. And I think because of this and so much that's happening, we really are extraordinarily lucky to be able to be practicing and doing clinical research in this time. And that's really, really important today and this year of all years, because we are really in a very dangerous place nationally where we have spent 30 to 40 years developing the American infrastructure to be able to bring real progress to patients. And we are really it's an existential threat right now for that to be taken away from us. I'm already in a situation where we talk with companies and they are moving all of their drug development to Europe and all of their drug development to Asia. And all of that delays our patients having access. And so I have found that there is nothing more powerful than patients and people who care about cancer patients speaking up publicly and speaking to media and speaking to their representatives. It really does have an impact. And so I just wanted to leave you all with that charge to really do more than you've ever done before, because it is going to be more meaningful now than ever before. So that's the end of my tailored talk, and I am very happy to answer any questions.
I'm very happy to give you questions, and so
Okay.
so thank you for that, for the excellent talk. That was a real once over. So I'm going to start with what they already posted in the chat, and so if anybody else has questions, go ahead and post them in there as well. But let me start first. One of the questions was specifically of KRAS AV11. And Dana asked, have you heard of KRAS AV11? And can you give us any thoughts on that?
Yeah, I mean, KRAS, are we talking about G12A?
No,
or
it's AV11, not G12A. AV, like audio visual 11 is what she posted.
Yeah, I'm sorry that I think that is not a mutation that I'm particular. There are many rare mutations, and that is not one that I am as familiar with. So I apologize, but I'm happy to take that back and look it up and come back to you.
Okay, great. And then next, do you have any insights on cholangiocarcinoma, specifically with G12V, like Victory?
Yes, absolutely. So cholangiocarcinoma is very near and dear to my heart. I chair the medical advisory board for the Cholangio Foundation, and we are, as a community, very committed to bringing KRAS inhibitors to cholangiocarcinoma patients. I think I can say with a lot of optimism that we are going to have a clinical trial for cholangiocarcinoma patients with KRAS inhibitors in the next year. There's a lot of reasons I can say that, but I think so absolutely. Don't have any reason to believe that KRAS G12V or any KRAS mutation that we know has activity in pancreatic cancer wouldn't have activity in biliary tract cancer. And I can tell you personally that I have taken care of patients with biliary tract cancers and KRAS mutations, and I'm very optimistic about these drugs for bile duct cancers.
Okay, good to hear. I'm just going to go down the list, so it's a little out of order as far as logic, okay? And this is one of the questions that we get asked a lot. Why there's a 1-to-1 randomization in the control arm when there's so much information already out there with standard of care treatments, and it's so well published, and it doesn't happen in any one cancer, it's all cancers.
Yeah, so every clinical trial that is reported has unique features, and the most important unique feature is which sites enroll to that clinical trial. So when you take an early clinical trial, a phase 1 study, which is the earliest study, for example, the daraxonrasib data that I showed you was from a phase 1 study that was open at 10 to 15 sites across the country. Now I think 20, but initially when it started and that data was reported, 10 to 15 sites. high volume centers that know how to take care of patients with pancreatic cancer. They are the world's experts, all the different investigators that were involved in that trial. And so while the drug did well, we know that our nurses and our staff and our infrastructure of clinical care at those institutions also makes a difference. And if you look at survival for patients for many cancers, and you look at a major academic center that would open these early trials versus the kind of national database, our patients live longer. And it's not because we're given the drug any better. It's because our nurses are better and our staff is better and all that. And so we cannot use old data as a control because that data is not representative of the real pancreatic cancer world and community. So when you do a big trial like this, it's open at 60 or 100 sites across the world. And then the control matters more, right? And so that's why when you do any new trial, you can't compare to data that has come before. And the other thing is that the landscape of care has changed, right? So if you look at overall survival, which is how long people live, as the endpoint, and you compare it to a study from 3 years ago, and there's been a new drug that's been approved or a new regimen, people's survival is different. So you can't compare it to 3 years ago when survival, I'll tell you, if survival for a certain cancer on average was 5 years, we start a new drug, it gets approved, and now average survival is 8 years. We can't compare it to the 5-year mark, right? And so that's the problem. And that's why the regulatory bodies make you have a control in every large trial going forward, because you have to compare it with current data, current care patterns, and broad institutions.
And it kind of sucks, but it's necessary.
Yeah.
And but it's a great question. So thank you for answering that because it's a hard part of hearing.
Yeah.
It's very hard. So onwards down my list here. Are there any targeted treatments or vaccines specific for KRAS G12A in the works or available?
Mm-hmm. Yeah, so there's the vaccines I mentioned to you, both of the vaccines that I mentioned to you have G12A in them. There are actually a couple of other vaccines that also incorporate G12A. It's not common enough that I think there's going to be a specific G12A vaccine that's only G12A. That might happen, but it's going to happen later, right? Having a pooled vaccine is reasonable and allows you to hit if you have an off the shelf vaccine, you want it to be able to treat as many patients. But yes, G12A is incorporated in that. And then also in terms of the KRAS inhibitors, multiple KRAS inhibitors that target multiple that are called multi-RAS inhibitors, also G12A is allowed on them. There are a couple of G12A specific inhibitors that are in the lab. I don't know of any that have moved into the clinic, but I'm not sure that we again need them. We might be just fine with a multi-RAS inhibitor.
No, okay. And when it comes to the vaccines, could you just kind of like just summarize how a vaccine for the cancer is different than just going and get a vaccine for like the mumps or something?
Yeah, so it has some differences and some similarities, but the overall idea is that when you have immune cells in the body, you want them to be ready to go after whatever is abnormal, right? So when you get vaccinated for the mumps, what you're trying to do is vaccinate children, usually, vaccinate kids and say, okay, even 10 years from now, if you get exposed to the mumps, you already have cells inside of your body that are ready to recognize that mumps virus is not right and it needs to attack it. And so in cancer, the challenge is that that cancer is already living there in your body. And so your immune cells are already, for whatever reason, they are not they've developed tolerance and they are not attacking the cancer cell because the cancer is there. And so what a vaccine is meant to do is to say, look, you have got to have some immune cells in there that recognize that there's a KRAS mutation. We need to amp up that response right now because right now you're not amping yourself up. You're supposed to, and you're not doing it. So that's why you use a vaccine. The theory is similar, but the reality of what's happening is a little different. So you're basically trying to get the immune cell to get kind of kick started because the cancer's cells are there and they're present and they're being able to establish themselves.
Okay, great. Let's see. Uh, Wow, we got a lot of questions, and so just bear with me because they're going to be like we're just going to be like pelting you like with
Yeah,
pepper.
yeah, yeah.
Okay,
That's what I'm
okay,
here for. Yeah.
okay. All right. Can you let the audience know if there's any pancreatic cancer trials with KRAS slots currently available at Hopkins?
Yes. And there are trials available at Hopkins, and there are trials available at most major cancer centers around the country. This is a very hot area of development, and every major center that does a lot of clinical trials is going to have it. So, it's important to kind of marry access to a clinical trial with life, right? And so it makes more sense if you live in Houston to go talk to the folks at MD Anderson. And if you live in Pennsylvania, maybe you come talk to us or University of Pennsylvania. So, but yes, all around the country.
Okay. And how do you decide who gets final acceptance into a clinical trial after a referral from a doctor?
So there's a few different things that go into it. Number one, do we have slots available? So slots come open and closed all the time. But when a slot opens up, we usually keep a little bit of a wait list of patients that have been referred to us recently. If there isn't a wait list, then I will reach out to all, so at Hopkins, we have 17 GI providers. And so I will, send a blast email to everyone and say, okay, we have slots on this KRAS study right now. Who has patients that are ready to go? And then if that doesn't get me the patients I need, then I have a referral area, like, for the DMV and Baltimore. And so I will reach out to that next level. So that's how I find patients. And then when patients come in for a clinical trial, educate them about the study. You give them a consent form that has all of the information. When do you have to come? What are the side effects? Everything. And then you have a screening process where you end up having basically you do blood work, you do extra tests to make sure that it's safe for you to go on study. And only if there's a slot and if you meet all that eligibility criteria, then you would go on the trial. So that's how it's decided.
But if you want to go through and get an idea, if you're going to qualify or not going to qualify, you can look at the inclusions, exclusions. And so for something on there, like, that you're going to be excluded because, I don't know, if you have brain mets or something like that, you can tell just kind of by looking the clinical
A
trial.
little bit, but I do think there's a lot of nuances to clinical trial
Oh, yeah.
eligibility. And so to me, I think it's a lot to put on a patient to try to have to figure out. And clinicaltrials.gov is such a crappy website. And so to me, I think the best way to do that is to either talk with your doctor, because your doctor should be able to help do that with you, or you do go get a second opinion at a place that is able to help you understand those pieces and look at you in that way. So at Hopkins, for example, we have a clinical trials referral team, and they go through, if someone reaches out to them, they gather medical records and then they go through the records and do a pre-screen to see whether the patient qualifies, because even if it says that brain mets are exclusionary, for example, if you've had a spread to the brain, sometimes it says it's exclusionary, but it just means exclusionary for 3 months. And then after 3 months, it's okay. So there's just nuances, kidney function. Sometimes we can use a different formula and kind of get somebody in. So I just think it's good to talk to somebody who can look at those nuances with
Oh,
you. Yeah.
yeah, definitely, definitely. Okay. What is available for Q61R mutations in pancreatic cancer patients who have had Whipple and/or prior standard of care treatment?
So right now, if someone has no evidence of cancer, then there is nothing available, and we, hope that they're going to do well and the cancer won't come back. If it does come back, then there would be KRAS clinical trials that are the multi-RAS inhibitors that target it. There is going to be an adjuvant study, I think more than one adjuvant study in the next 6 months that's going to open. And in that setting, depending on what the drug is, if it is a multi-RAS inhibitor, then that would be an option as well.
Okay. Let's see. Somebody asked that you could go back to the slide that identifies the vaccine clinical trial and CT numbers.
Sure, but I'm happy to put that up, but that is just the ones at Hopkins, so it's not exhaustive, but I'm happy to put it up.
You guys are kind of like really leading the edge when it comes to the vaccine trials that I've seen.
Yeah, it's been an area of our focus for 20 years now, so we're excited that finally we're getting some traction. Yeah.
Well, pancreatic cancer seems to be like a real special, like, particularly KRAS in general, seems to be a real specialty area within the Hopkins. I don't know if the mission, the statement, I don't know the tapestry of it there.
Yeah. No, I mean, I would say vaccines and immunotherapy, that's been part of our metric for a long time. And, KRAS mutations and just sequencing cancers are really kind of pioneered by the cancer biology group at Hopkins, led by Bert Vogelstein and his team, 30 plus years ago. So just the idea that there are multiple mutations and, in cancer. But I would say the KRAS space itself has been something that we've really been focusing on more the last 5 years.
Okay. Well, and it seems to me there was some sort of like a genetic study that you guys were doing there as well on pancreatic cancer patients.
Yeah, our pancreatic team has a whole kind of genetic susceptibility group that has been really at the forefront of people that have a genetic risk as well. So that has been a separate
Is that
area.
something that a patient that has pancreatic cancer or maybe something that's trending within a family, they should be considered?
Yeah, all patients, based on guidelines, all pancreas cancer patients should have germline testing done. It's about 5% of patients that will end up finding a mutation. And so it should be covered by your insurance and standard of care.
So what you're saying is ask for it.
Yeah.
Ask for it and make sure that you actually get a copy of the report. It just because they said they did it, it's really nice to have that. It just really, even if you don't read it and don't understand it, it's fantastic to just know you've got it.
Yes, and I will say that it is the thing that is most commonly not done when people come and get second opinions with us, is that it's very common for them to not have had genomic testing done for susceptibility. So definitely ask for it.
Okay. Let's see. All right. This is kind of like all over the place. You're going to have to work today for your, like earn your keep here. Okay. I was on RMC 9805 and had a great 9-month run. It lost its efficacy. I find a lot of the inhibitor trials are closed. Are you being considered ineligible as a result of being on the 9805 trial?
Yeah, right now, so what happens in drug development is that there's a whole period of time where people can only have one exposure to a certain class of drugs. So you get one shot at a KRAS inhibitor, you get one shot at an immunotherapy drug. And then over time, over too much time, over years, it changes so that now it says, okay, even if you've had it before, you can have it again, or you can have a different one. And so right now, if you've had 9805, which is the zoldonirasib drug, then it is likely, I mean, I don't know every single trial, but it is very likely that other KRAS inhibitor studies are not going to allow you to go on. But vaccine trials will. And in fact, my trial that I was talking about, the KRAS vaccine study, I have an entire arm that is purely focused on patients who have been on a KRAS inhibitor. So you can't even go on that trial unless you've been on a KRAS inhibitor, and then you can go on the KRAS vaccine immunotherapy trial because we have data that suggests that the KRAS drug can actually remodel that tumor microenvironment. And so our hypothesis is that those patients might benefit more from the immunotherapy vaccine approach after being on a KRAS drug. Now, the challenge of that is that you have to go on immediately after KRAS inhibitor. So if you have some other therapy in between, then that trial is no longer an option. But for any pancreas cancer patient who has been on a KRAS inhibitor study, they could come onto our vaccine immunotherapy trial as one option. But that's just one option, just giving.
Okay, but are there other than pancreatic cancer, because you were showing the colorectal, so if this is still going to be man, I'm really foggy today. I'm sorry. I feel I feel like I haven't quite recovered from the 4th of July weekend. I took a day off and holy cow, I'm like all over. There's still going to be options for them outside of just that.
Yes, definitely.
Okay. All right. And don't necessarily feel that chemo throws you is like a last ditch effort. There's a lot of people that have had I'm not a colorectal patient, but I've had chemo and I did adequately more than fine. I mean, there's been
I'm
people
gonna
who are alive for a long time.
give me.
All right, there aren't any drug immunotherapy trials ongoing for colorectal G12V.
There are many drug immunotherapy trials and KRAS drugs that are going on for G12V. Yes.
Okay. All right. Vaccine G13. Okay. All right. Is there a vaccine? Okay. Is there a vaccine for someone who happens to be a KRAS 13D oligometastatic? How come I can never say this?
Oligometastatic. I see that. I see it.
Oligometastatic. It'll happen with no current measurable disease with positive ctDNA. Okay. Is that somebody like you can get a vaccine for something like that, or is
Yeah,
that
so
considered
that
stable or what?
Elicio study that I was showing was actually a trial that would have been great for your dad. But that trial is fully enrolled, but that trial, like that is exactly the kind of patient that they were looking at as people who had already come off of their therapy. If your family member though has disease in place and they're on first line chemotherapy, then we have our vaccine study, for example, but that's for patients who are on chemotherapy within 6 months of chemotherapy and have pancreas cancer, but they have active pancreas cancer. So it's a difference than being NED and only being positive in ctDNA.
Okay. Let's see. I'm in Resolute 302 study for pancreatic on standard of care. Is there a hope I can get on to RMC 6236?
Not until the drug is FDA approved.
Can you give us like a sense of this? You and I talked about this when I was there. Give me a sense of like what this looks like, how long this is going to take in order to get this. Let's just say everything is met with endpoints and stuff, okay? And I don't have a crystal ball. Let's just say it does. How long is this going to actually take for a drug to be approved like this?
I would say that an ambitious timeline would be towards the end of 2026. 2027 being kind of more likely. Again, like some of it is based on how long the regulators take to look at the data. But that's why what my point of if you're randomized to standard of care, the better option is to really look for other companies' drugs, not daraxonrasib, but a different drug. And as you can see, there were many other drugs that are showing activity. And early trials, phase 1 and phase 2 studies, you definitely get the drug. So the benefit of that, while there isn't the same amount of data because that drug is just older, so there's more data, the benefit is that you definitely get the drug,
Can you kind of help us figure out what does this whole right to try and compassionate use thing mean? Because there's a lot of confusion around that.
So compassionate use, there's two different ways that can happen. When a drug has already finished its phase 3 trial or is showing a lot of activity in its phase 2 study and it's already available for another indication, then you can get compassionate use. Like you can apply, for example, like when immunotherapy was approved, right? PD-1 inhibitors were approved for one drug, one indication, but they were showing activity in other indications. You can apply for compassionate use. And then there's expanded access programs. So there's a few different ways. So expanded access is in that setting, right, where you're trying to expand the access of a drug that's available. But for most compassionate use programs, they don't this is just what companies generally do. They don't generally do that until their trial that's going to get their drug approved is fully enrolled. Because otherwise everybody would be applying for compassionate use and not enrolling in the trial. And so once the trial is fully enrolled, then a company can work with the FDA about whether they can release their drug for compassionate use.
And it's not a fast process.
It isn't necessarily a fast process, though. I do know that these KRAS inhibitor companies understand the feeling that everyone has, both from patient side and from the doctors that are taking care of them. And so they, I think, are very aware of trying to move quickly on these pieces, but right now they haven't fully enrolled the trial yet,
Okay, so stay tuned and let those trials enroll fully. That's what we're looking for. Let's see, why do patients always have to progress in their disease for them to qualify for a trial? Isn't it better to stay ahead of the curve?
They don't. It depends on the trial. So the vaccine study I was talking about, you can't have progressed. You have to still have disease that's under control and be within the first 6 months to do that vaccine study I was talking about. So it just depends on the study. There is a term called clinical equipoise, which is an ethical term that says that if a patient is doing well on something, is it ethical to take them off of that thing that is working for them to give them something that you don't know is going to work? And so that's why in many settings at the beginning of developing a drug, give it to patients once they've already had growth on something else, because taking somebody off of something that's working to give them something that couldn't work, that might not work, and then they could be in a really difficult position and never qualify for therapy again. That there are ethical issues there.
So equipoise is essentially, if it ain't broke, don't fix it.
Yeah, that's one way of looking at it. Yeah. And if you are gonna, and if you, or you need to have a fix that you're pretty confident isn't gonna hurt people,
Yeah. Okay. I did not hear anything specifically for KRAS G12R. Are there only multiple KRAS mutations?
No, again, there are drugs that are being developed for each one of these individual mutations as well. The more rare the mutation, the more interest. So the reason that everyone was developing multi-RAS inhibitors and G12D and now G12V is because those are the most common, right? So if you're developing a drug, you want to be able to develop something that helps the most people possible, and allows you to enroll your trials as easily as possible. But because there is so much competition in the space, as I said, dozens and dozens of drugs and companies in the space, we are going to see, and we already know that in the laboratory there are drugs that hit the other individual mutations. It's just when will they actually move into the clinic? People are going to prioritize the multi-RAS inhibitors at the top, right? And so that's why. But yes, they do exist and they are going to eventually move forward.
So again, I'm reading. So are you saying that the expectation is that the RMC 6236 may be more effective than standard of care chemo because the stage 3 trial is testing it's separate rather than the 6236 plus chemo versus just 6236?
So the Resolute trial is testing the concept that it is better than chemotherapy in the second line, meaning the second treatment that you got. So yes, that's the hope. That's how it would get approved, is if it's actually better than chemo in that setting. In the first line setting, it is being tested with chemotherapy in the early phase trial. So right now they're doing dose finding, where we're trying to figure out the right dose. In pancreas cancer, it's FOLFIRINOX or gemcitabine and Abraxane. Colon cancer, it's also FOLFOXIRI, same thing, or FOLFOX FOLFIRI. And so we are combining the daraxonrasib as well as Zoldan with chemotherapy and trying to find the right dose. And then the idea of that would be you could then compare it to either the drug alone or chemotherapy alone and see which is better. And then that's just the Revolution Medicine drugs. There are multiple other companies that are out there right now too, and they are also combining with chemotherapy. So we don't know yet what the best time to give this drug is. Is it to give it to people as the first drug that they give, or and to give it with chemo or without? But if lung cancer is any indication, we're going to see that as we move it earlier and earlier in people's treatment, it's going to help more and more. But we don't know if that's true. But that's what we've seen in lung cancer, right? So we would hope that we could use some of these drugs earlier and earlier.
When it comes to immunotherapy, how are patients doing with immunotherapy? Because it is such a different space, whether you're talking about lung cancer, you're talking about pancreatic cancer, or what have you. Can you just kind of like go through the highlights of it, the highlights, the lowlights of what it is that we need to know?
So immunotherapy for patients with colon cancer, microsatellite stable colon cancer, it's 95% of metastatic colon cancer, or with pancreas cancer, broadly speaking, has not been active. And so that's why we are working on a lot of different combination approaches and with new kinds of immunotherapy to try to make it work. And there's definitely progress, and there's scattered patients that have done well with I can name my particular patients that have been on an immunotherapy trial and have done really well. And, there's been some very high impact papers that have reported on one or two or a handful of patients that have done well. And also with adoptive T cell approaches, when you give people their immune cells back or modified immune cells. And so so immunotherapy is exciting, but it just hasn't come of age yet. There's not the kind of data for immunotherapy that we've seen in KRAS, which like out of the gate was active, right? So we didn't have to do anything to these KRAS inhibitors to see that they were active in most patients. With immunotherapy, we're having to do more, and we're still working on it. But the beauty of immunotherapy is if you can trigger someone's immune response, it can work for a really long time. So people develop resistance to targeted therapies, but with immunotherapy, there are people that I've taken care of whose cancer there's the hope of durable benefit, of years of benefit, or of even what we call complete responses. And so that's why immunotherapy is so important to continue to pursue.
All these inhibitor drugs are very exciting, but eventually patients do develop resistance to them.
Oh, that's
They
what I
do
was saying,
have to
yeah.
pivot. And so two parts to the question. First part is, are you seeing any sort of specificity when it comes to like acquired mutations, co-mutations or anything? And
Yeah, so there's
what's
been
next?
there's been great data that's been presented about G12C because that's where we have the most data, that there are multiple different resistance mechanisms of how people become resistant to G12C inhibitors. There's not just one way. And in fact, even in a given patient, there's not just one way. And so we're able to now use that to start designing some combination studies that are moving forward. And actually, there's a really nice abstract that was in lung cancer, so I didn't show it. But it was a nice oral presentation at ASCO this year looking at co-mutations in lung cancer and showing that some co-mutations predict for less benefit versus not. And so, yes, we're in a learning phase right now. And once we learn, then we can target, then we can be strategic. And so that's what's happening right now.
Well, is STK11 very common in colon and any of the GI cancers at all?
It's not very common, but it does present. So we do see them, especially in pancreas cancer, but it's not a very common co-mutation, no.
Is it something that seems to be leading at all as far as acquired risk?
We haven't, so we're that, again,
Not
we're
at all.
just starting to do that work, yeah.
Okay, okay. Yeah, well, and we've had Dr. Scolitas on a couple of times, and he loves talking about his STK11.
Yes, yeah.
Yeah, okay, so my wife has colon cancer with peri-mets. She got TCR immunotherapy for KRAS G12D. After about 8 months, there's been disease progression. She's scheduled to get a CRS surgery. The question is, should she get HiPEC or not post immunotherapy?
Yeah, I'm reticent to
Yes.
give advice on a
Yeah.
given situation because there is so much complexity and nuance to it. So I would say that is really a question best directed to your team and to a HIPEC specialist. And I believe when it comes to extensive surgeries that it's actually very much worth getting two opinions from two different surgeons, because it's the whole hammer nail thing with surgery. And so I think that's very worthwhile to do, but I wouldn't want to give you the wrong advice.
I think it's a great idea to get a second opinion when it comes to most anything.
Yeah.
I can't say that I just would go buy the first house that I walked into either.
Yeah.
Let's see. How do the P-DAC vaccine trials apply to patients with metastatic disease after surgery or other standard of care therapies?
So the vaccine study, the present study that I have open, is open for patients with metastatic disease af just after they complete their first line therapy and they have not progressed yet, right? That's one group. And then the second group of people are people who have metastatic disease, whether or not they had surgery before, both. You could have had surgery, and then they just are coming off a KRAS inhibitor. So those are the two arms of pancreas that I have. Other vaccine studies that are ongoing have been predominantly in the adjuvant space, but we're definitely going to see more vaccine-based approaches come up in all the different lines of therapy, but those are the ones that I know that are active right now.
Okay. So where did somebody get a list of like the vaccine trials?
I mean, again, clinicaltrials.gov or PanCan or the Les Garden Foundation, but PanCan in particular has a clinical trial search feature that you can look at. Pancreatic cancer vaccines are um, so I will say like Hopkins is the leader in pancreatic cancer vaccines in the world. And so
Yes.
if you have an interest in vaccines for pancreatic cancer, it's not the only place that does them, but it is the main place that develops them. Most of the other development is happening in companies. And so it is one of the major places that you could go to to
Would
talk to
going to
someone.
the Hopkins website with your clinical trials list be a good place to take a look at?
No, it's just not, honestly, it just isn't current enough. So, and it's got ba very basic information. So it's fine, but it's not, it's not going to do anyone who's already on this webinar is going to find it very basic,
Okay. And
basic meaning
just
simple.
and as a reminder to anybody that's in here, on our website, we do have a list of all the KRAS clinical trials. PanCan is good friends of ours, and so we're not anti-PanCan, and they help you trial match. We don't do that, but we do. There's a lot of times we're just finding information for a patient that has ARAS cancer is difficult, and so that's why we post that on there. And it's just kind of a PDF we're working through for other stuff in the future. Okay, what are the toxicity risks of the KRAS vaccines versus the targeted therapies or immunotherapies and whatnot?
I mean, so far vaccines are pretty tolerable. Like vaccines, you get a vaccine, it pinches when you get it. That's kind of when we give it with other immunotherapy drugs. Those have the side effects of immunotherapy, which amps up your immune system. But if you get the vaccine alone, they're really not, so it just depends on the given study.
Okay, so quick answer, depends.
Yeah.
But it's like any other shot, that part's not, there's just the easy part. When you guys do the clinical trials, it's like, well, this is a good question we get a lot. How are the clinical trials covered by insurance, or is it all covered by Hopkins? How does this all work? How do I know?
So clinical trials, it really does depend on your insurance. When Obamacare was, or whatever, the Affordable Care Act was initially put into play, one of the rules of Obamacare was that clinical trials had to be covered, but now that's been, I think, changed. And so it really depends on your insurance. And so generally speaking, the the company or the institution covers anything that's a research cost. So if you have to get a biopsy or some extra blood draws, or that's covered by the clinical trial. But everything that is standard of care. So if you were going to get a scan every 2 months, that's covered by your insurance. If you were going to get a blood draw before you get treatment anyway, that's covered by your insurance. And so your insurance has to agree to cover that. But the reason that some insurance companies bulk is that they say, well, if you're hospitalized, we're not going to cover it. If you're on a clinical trial and you're hospitalized and you have a complication, we don't want to cover it. But I would say in my maybe more than 90% of patients have coverage. So it's very rare to me that where I'm not able to put a person on. And if they aren't covered, I usually am able to appeal and kind of make my argument to the peer-to-peer person.
And that would be why I said you're a little bit of a firecracker, is because
Yeah.
you can tell that you would kind of like get up there and go nose to nose.
Yeah.
And, on behalf of patients everywhere, we need doctors that are willing to kind of like get up there and fight for us.
Yeah.
We're,
Yeah.
we're
Well,
not
and I would
ready.
say most people go into oncology because that's their phenotype. So I think, that is something that is a very reasonable expectation for people to have from anyone who takes care of them for something so serious.
Well, and we need to be able to have that sort of a rapport and that sense that that's what you're going to do for us. And so,
Yeah.
that's a recurring theme throughout cancer plans. Okay. Again, I'm just going through these lists. Okay. I know the answers, but I'm going to let you answer them. Is it workable for cancer patients to contact the drug company directly to go into a trial rather than apply through the medical provider?
No. I mean, you can, but the companies don't run the trials. They are not clinical providers. So they might, and many of them do refer you to, hey, these are the sites that you can go to, but they don't enroll patients in trials.
Yeah, and they can't. See, why do these trials require being given something with chemo? I failed 2 lines of chemo, and rather the chemo failed you 2 lines, and want to do a clinical trial, but can't find any. And I don't want any more chemo-related damage to my body.
There are many trials that do not involve chemotherapy. In fact, the only trial that I have that involves chemotherapy is one of my KRAS studies that has a chemo combination component. But almost all my other trials, and I'm not just talking about KRAS inhibitors, I mean, all the drugs that I use in drug development do not involve chemotherapy. So, that is not and then frankly, the further along in therapy that you go, the less likely chemo is likely to be a component of it. So
Well, and the
it may
earlier,
be the trials that the site that you're at has that for some reason are more chemo heavy, but nationally speaking, that's not the
and
case.
it's quite common that you need to make it clear as a patient, I'm talking to the patients now, that when the doctor says, well, we don't have anything for you here, they may mean here in our clinic. Okay,
Yeah,
that may
absolutely.
not necessarily, and you may like not hear the here part. Okay, when they say have nothing for you, that may mean at their clinic. And so you do need to go get another opinion. I saw recently that there may be able to use immunotherapy for KRAS G12D. Have any trials started for that?
Yeah, I mean, I don't know what exact drug you're talking about, but KRAS vaccines, for example, are G12D specific immunotherapy. There are T cell therapies, so now they're developing cellular therapies where that target G12D that they are giving to patients. So that could be what you're referring to. They're going to start making drugs that are conjugates that where there has two parts to the drug and one part binds to the G12D surface of where that kind of cell interaction is, and is an immune. So yes, there are things that are being developed, and in fact, some of those studies that I was referring to that have been reported on cellular therapy have been around G12D as well. So.
Would you kind of go into ADCs a little bit?
Yeah, so ADCs are a different class of drugs than KRAS inhibitors, and they are called antibody drug conjugates. And so they basically, generally speaking, have two components to them. One component binds to something on the surface of the cell, and the other component has what's a payload, and that payload delivers. It's kind of like a missile. So it's got a payload that it delivers directly to the cancer cell, and that payload is usually some kind of chemotherapy, usually. And so, but the idea is that that chemotherapy would be delivered directly to the cancer cell rather than being delivered to all your normal cells. And so the more that the part A of the ADC is cancer specific, the more specific that is for something that's only on cancer, the more likely the payload is only going to be given to cancer cells. So, but they're a whole huge area of cancer drug development right now with a lot of different things being, A and B in that setting.
There's so much war going on against the cancer here.
Yeah.
It's like I don't think I ever used such like a war sort of blowing up, attacking missile sort of conversation until I got into this
Yeah.
space. I've always been rather passive, I guess, in those sorts of things. Um, this may have been already been answered, but there are vaccines or trials you can suggest for somebody who's first line therapy and currently doing second line with Gemzar and paclitaxel protein bound chemo infusion.
Um,
G12R and P53. I'm not seeing that as anything specific to.
Yeah, I mean, I think P53 is a common co-mutation, and so I think looking at KRAS inhibitor studies that cover G12R would be a very reasonable thing to do.
Is there anything special for something like TP53 or any of the other ones? I mean, I know we
Yeah, I
already
mean, there
talked
are
about
some
how
new
early it
drugs that
is.
are being developed for particular P53 mutations. There's a P53 like Y220C drug that is kind of a drug that helps kind of reconstitute P53 for that particular group of patients. And there are more P53 approaches that are coming out, but it's a mutation that results in something going away, and it's a lot harder to bring something back that we need than to inhibit something that's too high, right? So KRAS mutations, you've got too much KRAS, and so you're inhibiting KRAS. But P53 is a tumor suppressor. You want a functional tumor suppressor, and so you're basically trying to bring something back that's already gone, and that's a lot more difficult
Okay,
to
that
do.
makes sense. That makes sense. It's easier to stop it, stop the momentum than it is to get things going, which has been my problem all day today.
Yeah.
Okay, can you confirm that all current pancreatic cancer, P-DAC, KRAS inhibitor trials, except the phase 3 RMC 6236, require completion of standard of care treatment before enrollment?
No,
I'm just reading
many,
this.
many of our trials, yeah, many of our trials are in the first line or in the second line. They do not require you to have had every treatment. They don't even require you to have any treatment. Just depends on the study.
Okay. I don't think that, did I read that wrong? Confirm all current pancreatic, PDAC, KRAS inhibitor trials. Okay. I don't know, the question just disappeared, so maybe it was just phrased wrong or I read it wrong. I could have very well read it wrong as well. That's wrong. The results of the most recent RMC trials were most recently presented. When were they presented? That was, I missed ASCO. I was at my son's wedding, so I a little bit even further behind on the
Oh, that
curve
seems
here.
like a much better. Yeah. So what is the
Honestly,
question? I'm sorry.
yeah, no, honestly, it was, I'll talk about me just for a moment. No, honestly, I felt like I missed out a little bit on the ASCO stuff because I have never really caught back up because when you're not there, you kind of like miss the whole flow. Um, so,
Okay.
yeah, so anyway, but and I completely forgot what I was talking about. I'm telling you, I have just completely lost it today. Um, let's see, open slots for PDAC, G12R have completed first and second lines of therapy, chemotherapy. It feels like I'm getting the same question over and over and over again about standard of line therapy and have we had anything? And I'm looking to see if there's anything that's a little bit different. Are the vaccines you're working on similar to the dendritic cell vaccines?
They are similar in that they're vaccines, but dendritic cell vaccines are different. There's a lot of different kinds of vaccines, and dendritic cell vaccines are just a different way that we use the vaccination strategy with dendritic cells, whereas our vaccine is a peptide-based vaccine, so we're really trying to use little pieces of what would make up the protein to stimulate the immune system. So they're a little different. Yeah.
Are any of these vaccine trials available across Canada?
Not the ones I'm referring to, so the Canadians have some trials that are the same and some trials that are different, and so so I'm not aware of that, I'm not sure.
Okay.
The person in Canada that I think is the most aware of kind of what's happening broadly in pancreas cancer is Jennifer Knox at Toronto or Princess Margaret, and she's would be a great person to reach out to if you're in Canada in that area.
Well, and as we kind of like come into, it feels like I've kind of got the same question over and over again, so I'm not going to really like go through each one, and so I apologize if anybody if missing anything in here that looks like really big. But would you just kind of like tell me, as far as like the clinical trials and when we're watching the space, what is it the patients need to be looking for? Which conferences would you suggest that we watch for? What data? Is it like, it's like, okay, ASCO GI is like a big one. Which ones are like, okay, these are really the premier ones we need to know about?
Yeah, so the challenge these days is that there's a meeting every month. And so the biggest meeting, the biggest clinical research meeting of the year is ASCO, which is in June of every year. But in GI cancer, there's ASCO GI, which is in January. There's the AACR, which is becoming more and more clinical. That used to be ASCO and AACR used to be kind of these two competing meetings. The AACR was all the science, and ASCO was all the clinical care, clinical work. But now much more is being presented at AACR. The Revolution Medicine data for Zoldan was presented at the lung data was presented at AACR this year, and so anyway, the point is So there's also AACR, which is usually in April. There is ESMO, which is in the fall. I think it's in October this year. There's ESMO GI, which is now just happened in Barcelona. And so those are the European meetings. So it's really whenever the data is mature. There's a meeting called SITC, which is an immunology meeting in November every year that is very immunology focused. Those are kind of the biggest meetings where clinical data is reported. And then there's all sorts of other smaller meetings where things can get presented to. But I would say like every 2 to 3 months, there's a meeting that is big.
Which meeting are you most looking forward to next?
So, I mean, I think that I'm not going to, but I'm looking forward to ESMO GI. Sorry, not ESMO GI, main ESMO, which is going to be in October. And then after that, ASCO. I'm a big ACR person. I really enjoy ACR. I think it's a beautiful bridge of the science and the clinical. But that's not till April. So,
Yeah, I like AACR as well.
yeah.
I like that a lot. Okay, and what else is it that you just think the patients need to know? Well,
I mean, I think that while there is significant progress that is being made, all of your questions, again, are emphasizing that it's not happening quick enough for people who really need these things now. And so I think the way that the US clinical research and healthcare system is, it just puts a lot of onus on patients to do a lot of the legwork. But it is worth it to do that work because things, I think you're also seeing even in people who are on this call that many people who were able to get access to some of these trials really were able to have benefit. So putting that effort forward early, as exhausting as it can be, I think is worthwhile to try to reach out to institutions in your area or and your area might be a little bigger than what if you are in South Carolina, it may not be Charleston, it might be Duke, and so just figuring out those key places that are within your radius and making sure that that radius is big enough that it really has, I see a lot of patients who are at great cancer centers, but that don't necessarily do a lot of clinical trial work. And so they might have 1 or 2 studies, but they don't necessarily have a large volume. And so, if you kind of go through the whole country, you can pick out, probably 30 institutions that do a lot of high volume work. And it's worth, in my opinion, getting an opinion at one of those places.
even though everybody's working on trying to make it easier to access, reducing barriers into clinical trials, they are where they are right now. And so if you're a patient right now, that's what you need to be looking for.
Yeah.
Is like how I can get some help and where I need to go for that right now. And so I think that's really kind of important as far as being able to know strategically what it is you need to be doing and formulating it for the next steps. Because like you were saying, maybe an inhibitor is the next best thing for you, but it's also going to be more limiting as far as what the trials will be subsequent to that. And so whether you're doing it in this order or that order may make it an incredible difference.
Yeah.
So anyway, all right. Well, with that, I mean, I'm going to give you I don't know if I'm going to give it back to you, but we had you booked for another 3 minutes, but I'm going to let you go a little easy on you because I'm worn out today. I don't know if it's the heat. It feels like 110 outside and I'm just brain fried. So anyway, but I really, really appreciate you coming in and doing this today. And we're going to be pulling through the slides and doing the videos and kind of putting them out there. And I know it's only because you truly want to make a difference for patients in the space that you do this, because you guys really do step out. You're working, I don't know, 90 hours a week or whatever it is. I don't know what it is. Honestly, if you count the time that you're thinking about us, whether we realize it or not, when you're at dinner or just taking a walk or whatever, I think we're always on your minds. And I know for you, we're always on your heart. And so I really appreciate you and all that you're doing to make a difference and for us as patients. And I look forward to seeing you at one of the next conferences.
Yes, absolutely. And Terri and Chris, I just think what you guys have done with this, and to be advocates for this group of patients that the timing of it being so beautiful, but really like making sure the information is getting out to the people that it matters most to. So it's a great honor for all of us that work in this space to be able to interact with you and your organization. And, anytime that that any of us can be helpful, let us know.
Oh, well, you'll always be hearing me knocking on your
Yeah.
door. So, but you guys keep doing what it is that you're doing. And as the data, and whenever you guys have data that's going to be like reporting out, okay, let me know. And if I
Oh,
don't
well,
know the
that's great.
people that are leading the trials, introduce me, or whether it's by email or in person or whatever, because that's where I can't keep up with everything.
No, 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 it's
And
impossible.
I know you can't either, but we expect you to. See, they don't expect me to because I'm just a dumb patient.
All right, you guys
Thank
have
you,
a
my friend.
wonderful
I really
night.
appreciate
Bye-bye.
you. Okay, thank you all. And thank you everybody
Bye.
for joining. I'm Terry with KRAS Kickers. Bye.